Okay, welcome everyone to session 2. We hope you enjoyed all the workshops you attended in session 1. This workshop is titled Responsibility to Rank, Public Systems Roles in Individual Well-Being by Kate and Cece. I'm Georgia and I'm going to be moderating this session. So before we begin, we're just going to go over some logistical information with all our Zoom stuff. So first of all, please edit your names just to your first names in your Zoom participant name. Please note that this session is being recorded, so if you do not consent to this, please leave this meeting now. In terms of sound, we ask that you mute yourself when you're not speaking so we can minimize distractions as the presenters are speaking. We also recommend that viewers put the screen in speaker view. And if you have any questions or comments during the presentation and you have access to the chatting capability, please send them privately to the moderator, which is me, by selecting moderator in the chat box. And for students, there may be times throughout the presentation when the presenters will ask for comments from the audience. So during these times, don't use the chat feature. Instead, please either raise your hand in front of your video to indicate that you would like to speak or come up to the D10 to share. And then I will call on you by name or room number, at which point you can speak to the presenters and to the rest of the group. All right, so now I will turn over the presentation to our presenters, Kate and Cece, and we hope you enjoy.
Hi, I'm Cece.
And I'm Kate.
And the title of our project is Responsibility to Rank, a Public Systems Role in Individual Well-Being. It's not letting me switch my tabs to the poll. We're gonna start with a poll. So I don't know if that's in a sharing setting. But while we figure this out, you can log on to Nearpod or scan this and type in this code.
So in the poll, if you're on right now, again, it's on nearpod.com. Please use the code on the screen in front of you. And for this poll, we would like you to consider this situation. It is the height of the pandemic and there is one ventilator left in the ICU. You are the ICU doctor in charge and you have 4 possible patients with COVID-19 to give the ventilator to. So who should receive the ventilator? And again, your options are first, a 67-year-old adult with chronic kidney disease. Second, an 85-year-old adult who has a life expectancy of only a few more weeks. 3, a 7-year-old adult with no pre-existing health conditions. Or 4, a 40-year-old adult who is an essential worker. Thank you for everyone who has submitted so far. And we invite you to consider what you answered here throughout the presentation.
And then our second poll is, what priority should schools give to student mental health care services when they allocate their limited budget dollars? Okay, thank you for your participation in these polls, and keep these tabs open because we're going to have a few more polls later on. So this presentation focuses on 2 systems, hospitals and schools, and we're going to explore their responsibility to provide vital care, such as life-saving technology and school-based mental health services to the public. specifically during a time of crisis like the COVID-19 pandemic?
One of the areas that we'll be focusing on is triage in crisis standards, and specifically in a public health crisis like the COVID-19 pandemic. What is a hospital's responsibility to patients most at risk?
And as far as school-based mental health, when students are at risk of harm, what is the school's responsibility to provide mental health support?
By joining these two topics, we came up with an ethical question that fit both. What is a public system's responsibility to prioritize individual well-being during a time of crisis? The COVID-19 pandemic is a public health emergency that has required the allocation of limited resources and forced clinicians to make the difficult decision as to who gets the needed ventilator, dialysis machine, or ICU bed. The pandemic has also required the development of crisis standards of care for use in the most extreme circumstances. Crisis standards of care use triage scoring guidelines that follow the utilitarian framework of maximization, which allocates scarce resources to those deemed most likely to survive long-term in order to save the maximum number of lives. At times, this goal can supersede the principle of justice by placing those in marginalized groups at the lowest priority. Racial minorities, specifically Black and Hispanic populations, have been disproportionately affected by utilitarian triage guidelines that seem neutral on paper, but are not as neutral when implemented. As a result of systemic inequalities regarding access to care, jobs, housing, and adequate education, these populations are fundamentally disadvantaged in scoring systems when it comes to their long-term survivability and their comorbidities. And those are pre-existing medical conditions that predated their COVID-19 diagnosis. So crisis standards of care take advantage of a tool called the SOFA score. And this is the sequential organ failure assessment that was developed in 1994 to diagnose the acute morbidity of a patient with critical illness in the ICU. It is most associated with the diagnosis of sepsis and the degree to which the patient's organs are experiencing failure or dysfunction. The SOFA score assesses the 6 major systems of the body, including the function of the liver, the kidney, heart, neurological system, and the clotting of the blood and your lungs. So each system is given a score from 0 to 4, and the higher numbers reflect a higher level of dysfunction in the patient. And physicians determine these scores by using individualized tests for each specific system. And although the SOFA score was not made specifically for COVID-19, it is widely regarded as the best scoring system for an ICU overflow in this particular virus. But as we will see, race, age, and socioeconomic status have an impact on the SOFA score, and failing to address these considerations clearly runs the risk of creating an even larger strain in health equity. So it's important to note that in the US, Black individuals are 3.7 times as likely to be hospitalized as white individuals, and Hispanic individuals are 4.1 times as likely to be hospitalized as white individuals when diagnosed with COVID-19. And in addition, structural inequalities have made it more likely for Black and Hispanic communities to develop comorbidities and have difficulties accessing routine medical care on average. Systemic injustices affect most significantly the development of comorbidities in Black and Hispanic communities like diabetes, high blood pressure, cancer, heart disease, chronic lung disease, cerebrovascular disease, and chronic kidney disease. As you can see from this graph, the combination of one of these conditions on the bottom plus a COVID-19 diagnosis results in a substantial percentage of deaths. So if these diseases occur more often in Black and Hispanic patients and are more likely to cause death when combined with COVID-19, then generally speaking, on average, The risk of death for Black and Hispanic patients with COVID-19 is greater than for white patients. And COVID-19 patients with these diseases may be more likely to have a higher SOFA score and a worse SOFA score than white patients. And this would mean that they would generally not qualify as easily for something like a ventilator as a white patient. So this begs the question, should identity-related considerations be taken into account when determining priority of one individual over another in crisis standards?
So now we're just gonna switch over to the background information of my topic, school-based mental health services. We are in what psychologists have recently labeled a mental health crisis that seems to be affecting younger children the most. 1 in 5 students have experienced a mental health problem, and yet 80% of those children don't get treated. From 2013 to 2016, the diagnosis rate for depression in children ages 12 to 17 increased by 63%. For this project, I'm mainly focusing on anxiety and depression in students. Anxiety is typically characterized by stress, worry, or fear that interrupts with a patient's daily activities. Nearly 1/2 of patients suffering from an anxiety disorder are also diagnosed with depression. Depression, or major depressive disorder, creates feelings of sadness and typically results in the loss of interest in both daily activities and hobbies. And it's important to note that these conditions often have genetic components, but can also be situational, meaning that life events and family issues impact the chances of developing a mental health problem. The 5 main models for current school-based mental health services are services provided by the district, mental health units within school health clinics, co-located community services in schools, integration into the curriculum, and then the full prevention, intervention, and treatment program. However, many schools don't have quality mental health care, and 10% have none at all. These are typically the schools that have students with greater mental health disparities. Mental health disparities refer to higher levels of mental health issues among disadvantaged groups, including those of lower socioeconomic status and racial minorities. Many students in lower socioeconomic families are more vulnerable to mental health conditions because of environmental factors like financial stress, substance abuse, and violent neighborhoods. And yet, people of lower financial status don't have the access to mental health care that many take for granted. In fact, 42% of the population saw cost and poor insurance coverage as the top barriers to accessing mental health care. Analysis of US Census Bureau data shows that in 2005, African Americans were 7.3 times more likely to live in high poverty neighborhoods with limited to no access to mental health services, just continuing the cycle of poverty and discrimination. And on top of all of these barriers, there's one overarching one: stigma. Almost 1/3 of Americans have worried about people judging their mental health problems, making mental health education and access so much more difficult. And as Kate discussed, disparities in access like these are also apparent in hospitals. However, it's unarguable that hospitals must care for the medical needs of a patient, while many people debate whether schools should really be involved in a student's life outside of the classroom. To hear your opinion on this, we created another poll asking the question of, what should a school provide for students besides classes and homework? And for this one, you can type a few words or a phrase into the box and it will show up here. And you also have the ability to like someone else's post. Okay, thank you for your responses to this poll. And as a follow-up question, just consider how these answers may vary across different generations. So the current generation has had more of a focus on mental health care than older ones, but even still, school-based mental health services struggle. Currently, there's an average of 1,401 students per one school psychologist, which is a ratio far from the recommended 500 to 700 students per psychologist. The shortage of psychologists is one of the many shortcomings of underfunded mental health programs. Mental health centers receive limited federal funding. The money to pay for them generally comes from state grants, partnerships with local hospitals or public health departments, or grants from nonprofits. However, as of fall 2020, more than half of all the states and the District of Columbia had barriers prohibiting schools from utilizing Medicaid, a federal and state program, to support free school based health services. The federal government reimburses states on average 57% for health expenditures, so this means that Medicaid does require a state investment. But in addition to these funding barriers, more than half of the states are limited to spending Medicaid only for students with IEPs, individualized education plans, IFSPs, individualized family service plans, or under the Individuals with Disabilities Education Act. 24 states require that these school based health services be documented in an IEP or IFSP, and even requiring the services documented is a barrier because these processes take time and are often difficult to work through. And we have to remember that many students with mental health issues may not have access to the resources required to obtain an IEP or IFSP. For the implementation of school-based mental health services, schools must stay within a fixed budget, which is established by the taxpayers and state aid. Districts have many mandates that they must adhere to that are not funded by state aid. Therefore, they must make choices as to how a fixed budget is spent. So if mental health is a priority for a district, the district must incorporate staff, training, and additional materials to provide mental health into its budget and may have to give up other important programs or activities in order to make room for mental health. A district can also ask the local residents to approve additional funding if they want to exceed their annual budget cap, and then those residents vote on it. So these budgeting steps are needed more than ever as a crisis such as the pandemic heightens disparities in both hospitals and mental health. This graph really just shows that because now as COVID-19 has shut down schools and taken many loved ones, rates of anxiety and depression are higher than ever. This graph shows the rates of depression now compared to before the pandemic, just stressing the idea that this problem needs to be addressed on a larger scale than it has been.
This is a side-by-side comparison of the stakeholders that helps us see the parallels between our two topics, specifically who has the power and decision-making capabilities and who is affected by those decisions. Unequal access, as discussed before, is also a feature linking the healthcare and school systems, which we'll be discussing more as we move forward.
The differences in access to healthcare in urban versus rural locations are noticeable in both hospitals and mental health centers. Currently, there's a lack of mental health services in rural locations, despite the fact that depression and suicide rates are higher than their urban counterparts. Racial and socioeconomic disparities are also extremely prevalent in hospitals and schools, possibly due to bias. According to the American Journal of Public Health, 2/3 of healthcare providers hold some form of implicit bias, unconscious stereotypes that manifest often in the medical field. Implicit bias has a large role in today's society as it limits job opportunities, access to education, and medical care across different racial and social groups. These disparities show the need for both justice and equity in healthcare, especially in hospitals.
In a public health crisis, or when crisis standards of care are implemented, hospitals tend to shift towards saving the most number of lives, which fails to consider how likely a patient is to have score-raising comorbidities or what factors are contributing to their shortened prognosis or long-term survival. For example, individuals living in select zip codes in the US like ones in major cities or ones where there's a high percentage of low socioeconomic status individuals, they are far more likely to become infected with COVID-19. Yet this factor is not considered when determining who gets priority for the needed resource. A utilitarian approach and a justice approach typically don't coexist together because crisis standards prioritizes those most likely to survive. A utilitarian approach is achieving the greatest possible outcome for the most individuals. A justice approach, in this context, centers around the idea of fairness and equitable access for each individual. These two principles commonly don't coexist together because we generally choose to focus on one, and we invite you to reflect on this statement. To achieve the greatest possible outcome, the quality of some individual care must be sacrificed. And as society, are we comfortable with this? We invite you to type a few words again, a few words or phrases that come to mind, even just a yes or no response, and then briefly read and tap the heart on some that you find interesting, some that you agree with, or maybe some that you've never really considered. Thank you for typing in a few words.
So when we make these sacrifices, it might show how we value certain individual lives over others. The statistics of Black and Hispanic communities and those of lower socioeconomic status are already the ones suffering the consequences.
When thinking of how life is valued in today's society, it's important to consider, what do crisis standards of care say about the value of individual lives? Some effort is being made to distribute vaccines to the most at-risk groups, like the elderly. But in contrast, the SOFA score under crisis standards of care is unlikely to give the elderly priority for the scarce resources like ventilators or antibody treatments. When the goal is to maximize long-term survivals, communities affected by pre-existing conditions are at a distinct disadvantage. Refusing to address these pre-existing disadvantages would be a significant ethical shortcoming for society. And this is because inequity is not a short-term effect. If not addressed, prioritization will affect life after a pandemic and generations to come.
So this is an image of a school-based mental health service budgeting plan created by the World Health Organization. Prioritization is used in three main areas within the implementation of mental health services. So for schools, districts must decide to prioritize mental health by allocating funding towards school-based health services. Services outside of schools must look at current disparities and then prioritize certain locations. And once mental health is implemented, counselors may need to prioritize certain mental health conditions or students.
This is a diagram of the SOFA score and how it ranks the level of priority. The lower the score the patients have, it reflects their higher prediction to benefit from that scarce resource. And controversially, patients with a high score reflect their low chance of benefiting from that same resource. And those with a high score will only be given resources if the patients in the red and the orange category have their needed resource. But as you can see, this score only takes into account medical prognosis. But should other areas be taken into consideration when determining priority, like how likely they are to have those conditions that may raise their score? So think back to the first poll question you answered, the one about prioritizing those 4 ICU patients for the needed ventilator. Were you thinking that you would have liked to have more information about each of the patients before deciding who got the ventilator?
And considering this current prioritization, is there any right way to prioritize? Especially during COVID-19, hospitals and school districts have had to choose between several good courses of action, using the standard of who will benefit the most from this, who needs this the most, or even by convenience. But this will always leave one group behind.
So, what is a hospital's or school's duty to society? Is it even realistic to expect large systems like these to act in the interest of individual well-being during a time of public health crisis? As it is defined, the goal of public health is to improve human well-being by improving health and related dimensions of well-being, and to do so in particular by focusing on the needs of those who are most disadvantaged. This points out the responsibility that we have, not only as larger institutions, but as members of society, to mitigate these inequalities, especially during times of crisis. It's easier to expect altruistic behavior from an individual, but it's almost unrealistic for us to expect large institutions and systems to carry out those same behaviors. That being said, if larger institutions completely abandon these ideals, individuals will be the ones to suffer the consequences. We invite you to imagine a world where hospitals and schools routinely ranked and allocated scarce resources to patients and students based on their likelihood of long-term survival instead of the urgency of their present need. If we become a world that determines priority based on long-term survival, for example, in hospitals, we permanently change what it means to have the greatest need. In schools, if we become a world that stops trying to prioritize those with the greatest need, then the school is not carrying out their responsibility of individualized care for each one of its students.
Finally, we must look into the possible consequences resulting from a lack of access to these health resources. So for schools, lack of mental health care results in poorer academic achievements, as well as the decline of student well-being. In the long term, disparities prevalent in communities of color and lower socioeconomic status will continue to deepen. This is also true for those denied life-saving care because of SOFA scores. On the flip side, there would be several consequences to increasing a justice-based approach. This may mean sacrificing the good of the most amount of people for equality. So with this approach, questions regarding safety, privacy, and boundaries of care are brought up. Do you agree with the idea that schools implementing mental health care may be playing the role of a parent?
And when resources are scarce, should social determinants of health be a consideration in resource allocation?
So we hope you continue to think about the role of hospitals and schools in our current society, as well as concerns regarding the boundary of care.
Thank you so much. If you have any questions, please feel free to ask them now.
Okay, thank you so much, Kate and Cece, for your presentation. There's a lot of really interesting intersections between your topics, and I learned a lot. So in terms of questions, we have time for a brief Q&A period. If you're on a D10, you can either walk up and raise your hand, and I'll call on you to unmute, or you can use the chat feature if you're viewing remotely, and just make sure to send them privately to me, moderator Georgia. All right, so we have a lot of questions already. Let's start with Clara. She's her hand up.
Hi, nice job, guys. That was very informative. I was just wondering, what do you think the responsibility of schools is to diagnose mental health issues versus like treat the mental health issues?
So in my research and this presentation, I mainly focused on psychologists who have a job to treat students, while psychiatrists can actually diagnose. And I don't think there are few, if any, school psychiatrists. And I don't think that psychiatrists in schools is necessarily a bad thing, but I am worried that the schools that can afford psychiatrists are the ones who are already at a disadvantage. So just like going back to our presentation, if we really want to distribute mental health care equitably, I think we need to be focusing more on the treatment within schools. However, diagnosing mental health care or mental health conditions is a whole other problem in itself. Many people don't realize that even getting diagnosed is a privilege. So I think that's something that needs to be looked into outside of schools. But for right now, I don't think it's something that schools should prioritize.
Okay, thank you. We have another question in the chat. How will these systems shift as the world possibly shifts back to normalcy? What will the evaluation change?
Well, in hospitals specifically, crisis standards are not really meant to be implemented over long term. So it's supposed to go back to the original patient, doctor, individualized care kind of treatment. And that's what we're used to. But that's because there's no limited resources that need to be allocated. So hopefully there wouldn't be as great of a need to try to save the maximum number of lives if it's back in a normal situation.
And then just as far as schools, I think because there's been such a large increase in mental health problems, schools are left with, larger issues to solve than before the pandemic. So hopefully this will push schools to think more about student mental health, even if it's just regarding mental health education. Um, and I'd also say schools have an increased responsibility to help the students most at risk, just in efforts to level the playing field within schools, but then also across districts.
Okay, thank you. D10 number 122.
Okay, so for Kate, I'm wondering if you looked into how incarcerated people fit into the disparities of COVID-19 and whether it's similar or different to the racial disparities. And for Cece, I'm wondering if you looked into mental health conditions other than anxiety and depression, and if so, if they would have a different impact regarding mental health budgets.
That's a really interesting question. So hospitals are meant to consider each individual in these crisis standards kind of in a blind way of just looking at just their medical conditions at that time. But as we kind of brought up, that's kind of not really considering how they may have got pre-existing conditions in the past. They may lower their scores. So if they live in an area in like a jail that doesn't really allow for the best medical care at any time, then I think that that raises a good question of what should be considered and giving more priority to those who don't have the best access to care.
And then for your second question, I focus mostly on anxiety and depression for school-based mental health. But when I was researching more about bias in mental health, I looked more into schizophrenia and how I think there's a statistic where it's saying like Black individuals are actually usually misdiagnosed with schizophrenia in place of a depressive disorder. And this is just going back to stereotypes of mental illness. But I think most of my focus was on anxiety and depression.
Okay, I think D10 233. Do you have a question?
Hi, I was just curious what both Kate and Cece thought about like what you two would answer for the poll, because after all your research, like what you guys would think.
Were you talking about the first poll question that we asked?
Yes, I was. Like which one you would give the ventilator to.
Yeah, so right away when you kind of look at it, you think like, oh, you want to give the needed resource to those individuals who are at a most, I guess at a stage where they don't have that much time left to live, because you could, I guess, consider that they need it the most, like their need is the greatest at that given time. But as I was researching this a little bit more, it was kind of more apparent that they were trying to take the path, like hospitals in general, of treating those who are most likely to survive. So those most likely to have, the greatest long-term survival. But I think that considering long-term survival is a really slippery, like kind of slope to go down, because individuals with shortened long-term survivals to begin with would be at such a disadvantage. So I would say, in my personal opinion, you need to go a little bit more away from those just likely to survive long-term in the best manner, and go towards a little bit more of those who are disadvantaged going into the pandemic.
I agree with Kate. And for the poll about the greatest possible outcome, I do think that it's almost, I think in some ways it's unrealistic to not have this quality of some individual care sacrificed. I mean, it would be ideal for that not to happen, but yeah.
Okay, we have a D10209, and then I'll go to the chat.
Hi. Sounded very much like a math presentation. Lots of talk about probabilities, right, and chances, and long-term effects and things. One phrase that I wanted either of you can go back to. You said, I think I got it right. Inequity is a long-term effect. Did I get that right? Could either of you expand upon that a little bit?
I think this is just going back to what we were saying about how these disparities deepened, and this inequity is something that's carried on beyond the pandemic. So especially in like mental health, and how mental health doesn't just go away after the pandemic. This is a lasting effect, and not addressing these issues will continue to create these problems. And so it's just kind of an ongoing cycle.
Okay, I'm going to read aloud a question that came through the chat to everyone. So, Cece, have you considered a school's ethical obligation to use best practices following the science of learning to prevent anxiety and depression that largely stem from poor instruction practices related to learning differences?
I haven't researched much on learning differences or how teaching might affect mental health, but that can be something to look into.
Okay, keep the questions coming. If anyone wants to come up to a D10, feel free, or use the chat. We have a little bit more time to discuss. Okay, we have another question coming in through the chat. So this question is, what is the most interesting thing you've learned through your research?
I think for me, I mentioned this briefly before, but just learning about how previous stereotypes surrounding mental health have carried into today and created a lot of that bias in the medical field. And just going back to that statistic of 2/3 of healthcare providers hold some form of implicit bias, and seeing how this is so much more apparent than we may first think was really interesting for me to learn about.
I think for me was learning about the different types of triage, especially in different countries. It's a little different than what we were discussing here. Sometimes they just take into account a lottery approach. So in order to give the ventilator, they'll just make it a random lottery. And that does introduce some bigger ethical questions, but I thought it was really interesting how different areas responded differently to this crisis.
Okay, thank you, Kate and Cece. We're going to wrap it up, so we have a small little break before closing remarks. Thank you, everyone, for your participation and your engagement. And you can hop over to the closing remarks Zoom. It's going to start at 11:35. Thank you again, and see you all there.